Hi, I'm Dr. Eti Ben-Shabbat from Brain Rehab Academy, and in this video I'd like to speak with you about the difference in the treatment you give in neuro rehab when you rely on the radiology report compared to when you actually look at the brain images. Now this is important because some clinicians think that all the information they need can be found in the radiology report. There's other clinicians who say, but looking at the brain imaging is not going to change anything that I'm doing clinically. And I know that there's many rehab clinicians who just don't know how much rehab specific information there is in the brain images or how to use it. In this video, I'll use two examples, and by the end of this video, you'll be able to understand why the radiology report doesn't have the information that you need. You'll also be able to see how brain images changes what you do in rehab, and also you'll have a roadmap for the three main rehab questions. And they are, how can brain imaging improve my assessment, my treatment, and my ability to prognosticate? The first example is of a 70-year-old gentleman who was in rehab for 2 months, and the team started talking about discharge. So one of the clinicians wanted to consult me to see what I think about where they can get to. The radiology report basically said a large MCA stroke without further specificity of structures affected. In terms of clinical care, the team was really focusing on trying to find a way to communicate with this person. They've noticed there were cognitive challenges to this person. They weren't quite sure what they were. And they've worked really hard to get this person moving and walking. And it wasn't that successful. It was very difficult to get them walking. There was quite a few clinicians that were required for that task. And they were wondering whether this person reached their full potential. When I was looking at the brain images, I saw that although it was a sizable MCA stroke, a large part of the motor system was preserved. I also saw that there were areas of the brain that were involved with cognitive functions that did not involve the frontal lobe that were affected, and therefore would cause me to think that this person will have significant problems organizing themselves, processing speed would be a problem, planning would be a problem. And my prognosis was this person should be able to communicate. In fact, this person should be understanding quite a bit of what's being said to them. This person will have some cognitive deficits, and therefore he will need some help with cognitive tasks or tasks that have cognitive load. And in terms of motor function, I expect this person will be able to walk and do some transfers. So yes, they might be able to go back to their pre-morbid status. However, they're going to need help at home because of their cognitive deficits. Having that information changes the assessment and the treatment. Because now the assessment and treatment of the language means that they really need to hone deep into how much this person understands, not just with standard tests, but perhaps with tests that rely on pictures, and then devise a system for communication in which pictures are used, in which his cognitive deficits are addressed, so trying to set up simple boards. In terms of cognition, it meant that they're going to need to assess more specifically what sort of cognitive deficits this person has. How is their ability to plan or not plan? And therefore, what sort of systems are set to support that? What kind of lists or charts could be provided to this person to help them follow, for example, ADLs? In terms of motor function, it meant that the clinician had to really tap into what sort of movements can be produced in an automatic manner. Furthermore, what can they give the family members to do with this person when they come to visit so that those automatic movements can come through faster? And then in terms of treatment, the aim is to provide treatment that is automatic, low on cognitive load, that is designed to bring back some function. There is no point for this person to do 1,000 repetitions of a very particular movement, and there's no point of providing too many explanations either. So viewing the brain images added a new level of understanding of this patient and their potential for recovery. And it also refocused the team with regards to treatment and prioritizing the treatment. The second case is of an elderly gentleman who had a fall. Before the fall, he was living at home and he did need a little bit of help with some physical tasks. The radiology report described subarachnoid and subdural hemorrhages. From a clinical perspective, the clinicians felt that they were pushing this person as hard as they could. They felt that he had a potential for recovery, but there was slow processing happening there and he wasn't really taking up the information that was given to him and he wasn't quite progressing at the rate that they thought he should. They were wondering whether they need to push him even harder at rehab. After looking at the brain images, I could see two things. One, that there was diffused axonal injury there, which meant that when this person fell, there was also additional injuries occurring to the brain except for the subarachnoid and subdural hemorrhages. I also saw that there was a small lesion in the brainstem in the area of the proprioception, which meant that the sensory processing of this person will be affected. After looking at the images, it was clear to me that this person should be able to go back home with a physical ability similar to how he was beforehand. However, it was also clear to me that because of the diffused axonal injury, he will need some cognitive support. In terms of what it meant for assessment and treatment, well, it changed quite a few things. In terms of assessment, if this person has a sensory component, it means that the clinicians need to hone a little bit deeper into the sensory deficits, because perhaps what this person needs is more of a sensory element to the motor training rather than task-specific motor training. In terms of cognitive function, assessment needs to address that, and speed of processing is particularly important in this case. And then, of course, the treatment will involve addressing those cognitive deficits, understanding that they're long-term, and therefore figure out a system in which you can support the support person to help with the cognitive functions. So this is another example where looking at brain images changes your understanding of your patient, your understanding of how far they can get, understanding the main problems they have, and therefore how you need to modify your assessment and treatment. I hope that you now understand just how important brain images are for rehabilitation clinicians. I hope you understand that the radiology report has limited information, but the images themselves can give you a lot more rehab-specific information and information that can help you improve your assessment, your treatment, and your ability to prognosticate. If you found this information useful, please share it with other clinicians who you think might benefit from it. Also subscribe to my YouTube channel and click the like button if you liked it. And if you want to know more about how to use brain imaging in the rehab context, head to my website where you can find lots more information as well as short and long courses. I will see you in the next video.